Failure to achieve or restore a patent airway can lead to hypoxic neurological injury and death in critically ill patients within a matter of minutes. A failed airway comes in two forms. Can't intubate, can oxygenate situation, where there has been 3 failed attempts at intubation by an experienced provider. However, there is an inability to maintain adequate oxygenation and ventilation via a rescue device. A can't intubate, can't oxygenate situation occurs where there is an inability to intubate the patient and alternative techniques are not able to maintain oxygen saturations above 90%. The first step in managing a high-risk airway is recognising its potential presence. They generally fall into 3 categories: the difficult airway, the failed airway, and the physiologically compromised airway. If identified prior to intubation, the factors which make an airway high risk can assist in formulation of strategies to mitigate potential morbidity from the procedure and identify appropriate rescue strategies. During a crisis, it is common to be presented with more information than can be processed. This cognitive overload impairs decision-making and can cause a clinician to become fixated on the task. Training in simulated conditions of stress can reduce reaction and response times. In addition, a team approach and effective crew resource management will assist with preventing this process. A clear declaration of failure at the end of each plan will facilitate progression through the failed airway strategy. As outlined in video 3, once a failed airway has been declared, Plan B is implemented. This will be a maximum of 3 attempts to insert a laryngeal mask airway. Repeated attempts at inserting an LMA increases the likelihood of airway trauma and may delay the decision to accept failure and move forward in the airway plan. If unsuccessful after the first attempt, consider changing the size of the LMA. And if cricoid pressure was applied, it should be removed as it decreases hypopharyngeal space and impedes LMA insertion. Plan C is the last attempt at rescue oxygenation by bag valve mask ventilation. A 2-handed technique will be utilised to attempt to ventilate the patient. Ensure appropriate patient positioning. If unable to ventilate and the patient has not yet been paralysed, paralytics need to be administered. At this point, the surgical airway kit should be performed. If unsuccessful ventilation, a can't intubate, can't oxygenate situation has occurred and should be declared. A cricothyroidotomy will be performed as Plan B. A cricothyroidotomy is a definitive rescue technique for the can't intubate, can't oxygenate scenario. The 2015 Difficult Airway Society Guidelines for Management of a Failed Airway has recommended a scalpel bougie tube front of neck access procedure. The equipment is readily available at almost every location where an intubation is being undertaken and provides protection against aspiration and unobstructed route for exhalation and provides the ability to monitor end-tidal CO2. This technique will be demonstrated here. Numerous studies have shown higher success rates of scalpel cricothyroidotomy in novice operators compared with cannula cricothyroidotomy. There is no evidence to suggest that commercial large-bore cricothyroidotomy sets are superior to scalpel tube techniques. Other than the can't intubate, can't oxygenate situation, another indication is massive oral and maxillofacial injury. Failure to provide oxygen to the brain may lead to anoxic encephalopathy and ultimately death. There are no absolute contraindications to a cricothyroidotomy, only relative contraindications. Guidelines cite varying age cutoffs, however agree that it is relative contraindication in children under 8 to 12 years of age. There is thought to be an increased risk of subglottic stenosis, and that due to their smaller airway diameter and pliable tracheal cartilages, even minor stenosis is more physiologically significant. Laryngeal fracture or tracheal transection is contraindicated due to cricothyroid membrane access being considered futile and the requirement for tracheostomy insertion. Finally, consideration needs to be given to if a cricothyroidotomy will effectively bypass the airway obstruction. If the obstruction is in the distal trachea, for example, performing a cricothyroidotomy becomes a waste of time that renders any future non-invasive ventilation ineffective. The major cause of failure of a cricothyroidotomy is misidentification of the membrane, which occurs in up to 70% of research subjects, with failure more common in females, patients with obesity, and tracheal pathology. The cricothyroid membrane is a small target. However, thankfully, there is surrounding anatomy to help you locate it. When no potential C-spine injury exists, extend the head and neck to foreground the laryngeal structures. Begin by palpating the laryngeal prominence, which forms the edge of the thyroid cartilage. In males, it's often referred to as the Adam's apple. In patients where the thyroid cartilage is not prominent, be aware that the hyoid bone might be mistaken for the thyroid prominence. Identify and palpate the cricoid cartilage, which is the next prominent cartilage below. The slight depression between these cartilages is the cricothyroid membrane. There have been alternative methods of identifying the membrane if the structures are not palpable, such as estimating the distance from the sternal notch. However, these have been shown to be less reliable than palpation. Ultrasound is the only technique shown to significantly improve accuracy of identifying the cricothyroid membrane and should be available for use when time allows. An understanding of the surrounding anatomy can reduce incidence of complications. The equipment required includes a cuffed endotracheal tube, size 6. Smaller diameters increase the work of breathing and are more easily obstructed by secretions. However, the outer diameter of the tube should not exceed roughly 9 millimeters to avoid damage to the surrounding cartilages. You also need a safety scalpel, an intubating catheter such as a bougie, 10 ml syringe, tube holder or cloth tie for stabilizing the tube after the procedure, antiseptic, gauze, suction equipment, bag valve mask and end-tidal CO2 monitoring, lubricant, and if available, a dilator and tracheal hook. Ensure PPE is worn to protect against blood and body fluid exposure. The potential for injury from the scalpel during this procedure is high. All precautions should be taken to minimise the risk to the clinician. Ensure adequate neuromuscular blockade and patient sedation. The patient should be on the stretcher, and unless there is a suspected cervical spine injury, extend the patient's neck to help identify the procedural landmarks. While assembling the equipment, the assistant should be oxygenating the patient as best as possible by administering high-flow oxygen through a bag valve mask or supraglottic airway, plus the use of nasal cannula. Note, however, that once the incision is made into the airway, positive pressure ventilation should be ceased, as it can insufflate the soft tissues of the neck and expel blood into the face of the operator. Prepare the anterior neck with an antiseptic solution. Ensure the patient's vital signs are being monitored. Stand to the patient's right side if you're right-handed. Place the thumb and middle finger of the non-dominant hand on each side of the thyroid cartilage to immobilize the larynx. This procedure is mainly tactile, so proper positioning is essential. Palpate the cricothyroid membrane. Make a vertical midline incision 3 to 5 centimeters long through the skin, overlaying the membrane. This vertical incision allows the extension of the incision should the initial location be too high or too low. If the laryngeal landmarks are not identifiable, the Difficult Airways Society recommends an 8 to 10 centimeter midline incision. Using the fingers, separate the muscles and identify the laryngeal landmarks. Reconfirm the location of the cricothyroid membrane with palpation through the wound. Incise the membrane by making a 1 centimeter horizontal cut. Make the incision with care. While there is a cartilage protecting the posterior trachea from perforation, excessive force can still lead to injury. While separating the cricoid cartilage from the thyroid cartilage, be careful not to incise or fracture either one. Once you've made the incision, the blade remains within the incision and is carefully turned into a vertical plane. Otherwise, it can be removed and replaced with a finger. Meanwhile, ensure the larynx is still kept immobile. If you're unable to stabilize the larynx due to obesity, edema, trauma, anatomy, etc., you may wish to leave the scalpel in until placement of the bougie. Other strategies include using a tracheal hook and tracheal dilator to maintain the patency of the airway. With the bougie pointing away from the head and parallel to the floor, gently insert it into the trachea until resistance is felt. Railroad a lubricated endotracheal tube over the intubating catheter until the skin is positioned between the two ETT position markers. If the incision is too narrow, general tube rotation may be required. Note the length of insertion. Whilst holding the ETT, carefully remove the intubating catheter, being mindful of any secretions. Inflate the cuff of the tube with sufficient air required to provide an effective seal and prevent ETT dislodgement. Inflate the balloon carefully until the balloon indicator is full but not tense. Overinflation increases the risk of pressure-related injury to the tracheal mucosa. Connect the resuscitation bag and commence ventilation by the bag valve mask. Confirm correct tracheal placement by observing an appropriate continuous and tidal waveform. The airway can be secured by cloth tape or commercially available devices. The Queensland Ambulance Service carries a Thomas tube holder which can secure the device. Care should be taken to avoid excessive tightening around the neck, which can lead to obstruction of CSF outflow, internal jugular vein, or common carotid artery compression. If available, use a flexible connected tubing to avoid tugging and pressure on the tracheal wall. Reassess the patient and regularly monitor their vital signs. Administer post-intubation sedation as required. In Queensland, this is the form of titrated aliquots of morphine or fentanyl and midazolam. Assess and adjust the ETT cuff pressure as required. Further follow-up care is provided by the receiving hospital. Complication rates vary widely and depend upon the patient population, the clinical scenario, the clinician's level of training, and the location the procedure was performed. The most significant complication will be risk of hypoxia and death. Other complications include the following.